Hello and welcome back to part 2 of what a urologist needs to know about prostate imaging. In this section, we'll cover how to read a multiparametric MRI with regards to lesion-based reporting and zonal anatomy. My name is Dr. Art Rastenhad, and I'll be taking you through this portion of the course. Before we begin, we always have some disclaimers. This course is for educational purposes only. It allows our physicians to review the material after attending one of our hands-on courses. It is not to be used to direct patient care or a substitute for actual hands-on training. First, you and your radiology team have to agree on a standardized reporting. Lesion-based reporting has been discussed in the new PIRADS 2 update, as well as this is what we used to perform at our institution. You should have a generalized location description. Where is it? The next is in the apex mid of the base. We developed and used the NIH zones, but you can also use the PIRAD version 2 zones, which I'll discuss later, which are almost identical. It's important to have the series and the images that the lesion is present on. For example, it's located on series X, image 11 to 16, where the center of the image is 15. This will help you target the most optimal portion of the lesion. Each sequence should have its own scoring system. I did show you a scoring system that we used at our institution, but you can just use the PIRADS version 2. It's important to have a concise, focused lesion report and then a summary of the overall 5-point risk stratification of 1 to 5. For completeness' sake, I am including our simplified qualitative scoring system. This was an idea of just stratifying a patient's risk based on the sequences as seen in the first section above. Positive, mild, or negative. We assigned a basic point value. Then we further stratified by findings of size, T2 morphology, and was the B2000 positive or negative, or was there type 3 focal enhancement to improve our risk stratification. These are the NIH Modified Zones. This was been presented in multiple publications, as well as this is what we use to hopefully communicate with the urologist and the radiologist. You see the blue, that's the peripheral zone, as well as the yellow, which is the central gland, and the anterior fibromuscular stroma shown in green. As shown here, our initial zonal anatomy laid out by numbers. Notice how it's very similar to the PIRADS version 2, which is on the right side of the screen. We developed this zonal anatomy by numbers to create stacked cells to keep track of different portions of the prostate in numerical fashion. However, it's extremely easy for us to convert to PIRADS version 2 from this numerical zonal anatomy. In the future, we can use the PIRADS 2 version zonal anatomy and convert it back to create our number matrices to do future analyses. What is the most optimal approach for scoring? Well, we feel there's a combination between the objective findings and some subjective interpretation in regards to the patient's history, but this all is summarized in the overall suspicion score, which is based on the PIRADS version 2 or your institutional's 1 to 5 Likert scale. This overall suspicion score of clinically significant disease was originally presented by Dr. Choiki. Using the original ESUR guidelines, they were looking at a 1 to 5 predictability, which is highly likely of having prostate cancer, which is a 5, having clinically significant disease. We found that these numbers didn't really hold up for clinically significant prostate cancer, however, did correlate with the risk of cancer detection on targeted biopsy. Clinically significant disease was less, however, did follow a direct linear relationship with an increasing score, increasing the risk of having clinically significant prostate cancer. This is a study from our institution looking at the overall suspicion score that we use versus PIRADS 2. I think this is important to highlight that the performance is slightly different, but why? It depends on how you approach the situation. This slide is here to show you that your scoring systems can impact your outcomes and counseling of patients, and it's important to have the feedback with the radiologist to optimize your understanding and scoring of the prostate cancer suspicion scores on multiparametric imaging. Even looking at clinically significant disease, the PIRADS 2 doesn't stratify risk as well as our overall suspicion score. Why is that? You should need to understand how scoring systems are done. The PIRADS version 2 tried to decrease the amount of 3s, or clinical suspicion was equivocal, which says that it wasn't sure if positive or negative. Essentially, that's the same as the risk of having an elevated PSA and a positive biopsy, which is about 40%. so they move to each side of the spectrum. That inherently decreases the performance of the test by grouping the patients in high or low without allowing the smoothness of the curve with our scoring system on a 1 to 5, with patients being included in the 3 category. Not to say one is better than the other, but I think if you have an MRI visible lesion, that patient should be biopsied, or at least followed in some way or paradigm at your institution. Having a PIRADS version 2 visible lesion does not mean that patient does not have prostate cancer. And all these numbers that are presented to you do not apply to what goes on at your institution. You guys need to develop individualized treatment plans and understanding what the predictability of your scans are in relation to your patients. When reading MRI, you need to pick your sequence. You should use an interface that allows you to review multiple sequences simultaneously. One sequence at a time does not work. You should first look at the peripheral zone first, then the transition zone, and what you find, what's positive. Well, T2, signal intensity, is low or dark spot. ADC is also a dark spot. A B2000 diffusion weighted imaging is the opposite. It's a bright spot, which I showed you earlier about diffusion weighted imaging. As you increase the B value, the brightest area, the areas of signal are cellular restriction. DC or contrast are just enhancement. They're usually bright. And always don't forget to look at the bone, lymph nodes, and is there any extra prostatic extension disease. And one of my pet peeves or things I try to highlight in these talks is don't forget the patient's history. It's important for the radiologist to understand what his PSA is, his biopsy history, his family history, because this can help him stratify risk and maybe improve the interpretation of their scoring systems to allow you to have more meaningful outcomes for your patients. You don't operate without imaging, and radiologists shouldn't have to work without patient histories. This is our first case. There's a lesion located in zone 7, or the anterior fibromuscular stroma. It's a 59-year-old Caucasian gentleman with no family history of prostate cancer. His PSA velocity is elevated at 2.15 nanograms per milliliter per year. His PSA is 8.27 with a free PSA of 11%. He had 3 prior negative prostate biopsies in 2010, 11, and 12. These are our T2 weighted images of this patient's prostate. As I mentioned before, there's a lesion in the anterior fibromuscular stroma. If you look at it, see this area, charcoal sign of low signal, and you're looking at it, you can see it down here clearly. Sometimes you're not able to see this well, but there's an area of low signal here as well. That's the coronal image. This is an ADC map and a B2000. Again, I said zone 7, or the anterior fibromuscular stroma. Can you see the area that's suspicious? Again, it's right here and right here. Remember, ADC map, low signal, diffusion weighted imaging, high signal, bright area. Again, this is a dynamic contrast enhanced MRI. See the area of increased enhancement or homogeneous enhancement here? This is consistent with the other sequences. This raises our suspicion of prostate cancer. This is the zonal report for this anterior fibromuscular stroma lesion. This has been scored in our standard scoring system from our institution, as well as the PIRADS version 1 at the time. But I think it's important to understand the nomenclature. You notice how it says series 6, image 11 to 13, center image 12. After looking at the films, it makes it easier for you to look at that specific area. This is a summary of the lesion, looking at in multiple views at the same time. Notice the anterior fibromuscular stroma lesion, the coronal, the sagittal views, the ADC map, the B2000, and the dynamic contrast enhanced MRI. So as you, the urologist, if you were told that this was on this sequence at this slice number, you're able to find those specific areas without difficulty. This is an example of the MR ultrasound fusion guided biopsy. Again, the primary zone was shown there, which is similar to the PIRADS version 2 zones, and you can see that the core needle went through the anterior portion of the prostate where the lesion was. And this was found to be Gleason 4+3. Case number 2 is a 67-year-old Caucasian gentleman who had a prior negative biopsy, and his DRE was negative at that time. He was referred to us when his PSA increased to 4.8. His PSA velocity is within normal limits. He does have a strong family history. Again, look at the top of the screen. Zone 4 is there is a band, or in the right peripheral zone anterior. The T2 weighted triplanar sequences are shown here. Can you see the zone 4 band or the right peripheral zone anterior area? Notice, do you guys see this? Right here, there's a thick band. We try to appreciate the band over here. It's a little difficult to see, as well as the band is represented here. It's important to understand you see these lines that traverse the images in the other planes. It allows you to know what axial slice you're looking at and be able to correlate that with your current imaging. This is the ADC map and the B2000 sequence. Are you able to appreciate the zone 4, the right peripheral zone anterior lesion? It's right here. Notice the area of high signal in the B2000 in the same region. Moving on to the dynamic contrast enhanced MRI. This area right here, you see this area of focal enhancement. It was found to be type 2 enhancement curve. In summary of this lesion located in the right apex peripheral zone anterior, it was centered at image 7. See the T2, the diffusion weighted, and the enhancement findings? This concise report allows us to create an overall score. The overall suspicion for this lesion was a 3 out of 5 due to its small size. It was 6 by 3 by 3 millimeters. Please take a moment to appreciate the PIRADS2 zonal anatomy. I think this is extremely helpful. Once you get used to this, you're able to scroll through an image and find the exact area of suspicion that the radiologist is trying to lead you to. This is the summary of the case. See the blue arrows? This highlights the region of interest that we've appreciated individually in the prior slides. This was biopsy and it was found to be a Gleason 8. It was a thick band. Sometimes when we biopsy very small lesions, there's a sampling error that causes upgrading. So only one focal area of pattern 4 was appreciated. Therefore, this patient was given a 4+4. Our third case is a 77-year-old Caucasian gentleman with a positive digital rectal exam. His PSA was 5.85 nanograms per milliliter and he had a free PSA of 22%. His PSA velocity was normal. However, he did have a brother with prostate cancer. Before we go to the images, I want you to look at the top of the screen. This is a zone 3L focal lesion, or a right peripheral zone posterior lateral lesion. In your mind, think about where this is located. I've showed you those zonal anatomies. This will help you look and find the lesion. Can you see the lesion without me helping you? Please look at the T2 weighted imaging as well as the ADC map, the contrast, and the B2000. Do you see it yet? Think about this. The patient had a positive digital rectal exam and has a lesion located in the posterior zone lateral. Right here. Do you guys see this wedge defect? Again, it's seen on the ADC map. It's focal, it's large. Look at this on the coronal. Very clear, large lesion. It enhances early as well as restricted on B2000 or has a high signal. Here's the concise report. Think about what the images that you just looked at. Lesion number 1, location of the right posterior lateral peripheral zone at the level of the apex. The zone was 3L, or PIRADS version 2 is peripheral zone posterior lateral. It all starts to make sense now. You're able to look through the images and find these specific spots, especially if I told you the anatomical T2 was series 6, images 11 to 15. The center was 13. Do you think you can find that? It's important to have these three-dimensional volumes if you're going to be doing research. And then, of course, it's scored in our scoring system as well as PIRADS version 1 scores. Notice the zonal anatomy again to reinforce where you can localize and find lesions. This was biopsied under a target biopsy. It was a 0.8 cc lesion and it was Gleason 4+3. Our fourth case is a patient with peripheral zone abnormalities that was a non-specific findings on T2. So the entire peripheral zone, from the anterior peripheral zone all the way to the contralateral side. This patient had a father with prostate cancer diagnosed at 75 years of age. He had 3 negative prostate biopsies, and they were read as diffuse high-grade PIN. His PSA continued to increase. It was as high as 12.17, and his PSA velocity is 3.85 nanograms per milliliter per year. So looking at this patient, I think this is a perfect candidate to undergo a multiparametric MRI of the prostate. With 3 prior negative prostate biopsies, performing a fourth one has a less than 10% chance of having cancer detected. However, with imaging, this is a very interesting case. There was some abnormality that was non-specific. We were unsure at the time when we were evaluating this patient. He had non-specific ADC restriction as well as a diffuse enhancement with a high B value in the lower right-hand corner, B2000 positive. After reviewing the MRI and counseling the patient, we selected areas within the diffuse area of suspicion that seemed to be higher risk than the surrounding areas. We were able to sample these specific areas as well as complete a standard 12-core biopsy. Once a pathologist had the additional information, we were able to give the patient a diagnosis of a Gleason 4+4 disease in the high-risk areas as well as intraductal carcinoma throughout the rest of the gland. This was a unique case because of that diffuse high signal appreciated on the B2000 sequence, which we hadn't seen before. Again, I try to reinforce the prostate zone so you understand that there's a way to communicate between you and the radiologist, that you are able to go to specific areas within the sequence to localize these lesions for targeting. As we move through the cases, I am decreasing the history to hopefully get you looking at imaging more. This is a gentleman with some posterior zonal abnormality. Can you see the zonal abnormality that's present on this image? Would it help if I told you this was located in the peripheral zone posterior lateral on the right? Do you see the abnormality present? Located right here. Another abnormality. See this? Starting to become clear to you at this point? This area was biopsy using an MR ultrasound fusion guided biopsy, found to have Gleason 4+3 prostate cancer at the apex. Looking at the findings, the ADC value was less than 900. We gave that a PIRADS 4, but he had type 3 focal enhancement, which was PIRADS version 1. We gave that a 5. Case 6, a 65-year-old Caucasian male with no family history of prostate cancer, with a PSA of 11.4 and no prior prostate biopsy. Looking up again, this is zone 3 or a right peripheral zone lateral lesion per the PIRADS 2 zonal anatomy. Now, you look at the film. Are you able to see the lesion yet? Do you see it on the sagittal or the axial T2s? Very clear, right? And some enhancement. Now, what is going on over here? Why is there this abnormality located? For some reason, there's some warping or changing the ADC map. Well, there's still some restriction, but the patient does have a left hip replacement, which can affect the images that are obtained. In summary, the patient was found to have a Gleason 3+4, almost a 0.5 cc lesion located in that right peripheral zone lateral. His ADC was restricted, and we talked about why there was an abnormality in the defect due to his hip replacement. He had type 3 focal enhancement. He had an overall suspicion on our scoring system of 4 out of 5. Notice here that the fusion appears to be off during the target. During a fusion biopsy, sometimes when the needle is placed, the prostate rolls away. It's important to keep your eye on the ultrasound to make sure that you're able to sample adequately the target. And on the bottom, this is the MRI imaging of the segmentation and targeting, but please understand that when you're actively doing something, the prostate can move, and you should be able to compensate for that during the procedure. Case 7, a 61-year-old Caucasian gentleman with no family history of prostate cancer and 2 prior negative prostate biopsy. His PSA fluctuates up and down, and this is all too common in the patients that we do see. Before we go to the images, see that this is a zone 5A focal lesion, or the transition zone anterior on the right side. Do you see the lesion? Looking at the imaging, there are some arrows here, but notice how the prostate looks completely normal around the blue arrow, However, the yellow area shows a mass effect of an anterior lesion. This was a very interesting case. The reason when you do an ultrasound biopsy, notice this would probably look like a normal prostate to you. However, this large anterior abnormality, which was seen on MRI and the ADC map as well as the enhancement, shows this large anterior lesion. This is the coronal in the middle lower pane. The patient underwent an MR ultrasound fusion-guided prostate biopsy. He had Gleason 8 found on the exam. And again, look at the prostate zones, 5 anterior or the transition zone anterior. It makes it easy for you to find these locations while looking at it. And what we did find in some of our research is that an ADC value less than 600 is a good decision point when looking at central gland tumors for increasing the predictability of having prostate cancer. Case 8. 59-year-old Caucasian gentleman, no family history of prostate cancer, 2 prior negative prostate biopsies, 1 in 2007 with a PSA of 5.1, and 1 in 2010 with a PSA of 7.0. His PSA currently is 12.5, with 11% free PSA and an abnormal PSA velocity of 0.85 nanograms per milliliter per cc. Again, before we go, look at the top of the screen. Zone 6A, a focal defect in the transition zone anterior left. Can you see the lesion? Please look at the ADC map. Maybe that helps you if you look at that first, and then look at the T2 weighted axial sequence. And then look at the lower right B2000. Do you see all the abnormality? It's very clear. This is the T2 abnormality. This is the ADC map. Enhancement wasn't that abnormal, however the B2000 was positive right here. This may be the lesion in the coronal as well as a lesion here in the sagittal plane. As you move through these cases, I'm hoping it becomes easier for you to localize your eye to go to specific areas. It is difficult to interpret prostate MRI, but as a urologist, our expectations are that you're able to scroll through a sequence that's already been reviewed by the radiologist, and you can find and make sure that you're targeting the correct areas for your procedures. This patient's MRI was read as a PIRADS 4, that charcoal sign we talked about. The ADC value was 488. It was diffuse type 3 enhancement with an overall suspicion of 3 out of 5. It was over 3 centimeters from the posterior rectal wall. Therefore, when you had your biopsy, you're not able to reach the top of the prostate. This is the fusion biopsy. See the lesion? Each one of these markers is 1 centimeter. Therefore, you're not able to reach the top of the prostate to sample this under this traditional 12-pore biopsy. See here, this is the segmentation on the ultrasound. Notice there's some indentation during the imaging. This you need to be able to compensate during the procedure to be aware of what is changing to optimize your biopsy approach. In summary, T2 imaging has a low signal intensity. The charcoal sign or the low signal seen in the peripheral zone are very clear, as seen here, as well as over here. Again, on the ADC maps, you're looking for the low signal. Do you see the area of low signal? How about on the B2000? That's the area of high signal, or the bright spot. Again, here is the dark spot. And this is the diffusion weight imaging from that previous case of that central gland tumor. See that area of high signal? It's always important to understand what you're looking for on each of the sequences. DCE, dynamic contrast enhanced MRI. The anterior fibromuscular stroma, or the zone 7, never enhances. If it is enhancing, an early enhancement, most likely this is prostate cancer. So it's important when you review your images to look at this area specifically. Also, since it's very fibrous tissue, on ultrasound it shows up to be part of the prostate. But when you do your segmentation of the MRI, you may look at this and skip this because it doesn't have that bright signal associated with the peripheral zone or the central gland. So be aware that your segmentation errors can occur if you're not paying attention to what at the anterior fibromuscular stroma is included in your prostate MRI segmentation. I'll be going over that in a different talk. With the development of multiparametric MRI imaging, we needed a way to correlate MRI findings with whole mount histopathology. Marcelino Bernardo, in collaboration with Dr. Choiki and Dr. Turkbay at the NIH, were able to develop a way to create a 3D mold based on the MRI. We were able then to slice the prostate on the same exact axis as the MRI images are obtained and develop a way to correlate the histopathology. We reported a positive and negative predictive values to be greater than 90% correlating with MRI and whole mount histopathology. Looking at extraprostatic extension, on a per lesion basis, our sensitivity and specificity was 85 and 99%. However, when we looked at the overall for the entire gland, if extraprostatic disease was found or not, the sensitivity and specificity did decrease. Another important study published was looking at the correlation between MRI tumor volume and whole mount histopathology. This was a study of 135 patients. This was done at 3T with an endorectal coil. The MRI's area under the curve and predicting tumor volume was 0.94. It overestimated the size of the lesion by approximately 7%. Taking this into account, there was a recent publication at 3T without a coil, and they found that the MRI underestimates the size of the lesion by a significant amount. However, I think it's important to understand that when you perform an MRI at 3T with an endorectal coil, you do get better results, and I think these results between the two studies does support this conclusion. After going through and learning how to recognize lesions, well, the bigger picture is what's the application of this new imaging? Well, staging, you can look at extraprostatic extension, which is typically what MRI was developed for or used for initially, which is 80 to 91% accuracy. Seminal vesical invasion is approximately 97 to 99% accuracy in determining if there's invasion. But the biggest gain is intraprostatic evaluation with increases in signal strength from field strength as well as using endorectal coils. There's an increase in delineation between normal tissue and prostate cancer. And the big difference is you evaluate 100% of the gland using imaging instead of the 12-core biopsy, which only evaluates 0.4% in patients with an elevated PSA. Looking back at MRI, there were common statements made that MRI is non-diagnostic. I think this is false now. However, then there was a lot of limitations regarding field strengths, quality of imaging, and even interpretation. And this is all fall by the wayside. We're able to now to look at intraprostatic anatomy with some accuracy. The cost and the time to obtain MRI has decreased. As stated, we initially used MRI to assess extraprostatic extension with an accuracy currently about 80%. I think the big picture here is we're not using nomograms. We're actually using patient-specific information to counsel patients, diagnose, and possibly treat these patients, which is, I think, a big shift in the paradigm that we need to appreciate as urologists. I'd like to say thank you for taking the time to review this session of the course. Please subscribe to our YouTube channel to continue to find updates and new course material. For additional material, please visit our website at interventionalurology.com. If you have any questions, please tweet at me at Dr. Rastenhead #, and any comments, please #MRFusion. Thank you so much for your time, and please stay tuned for more updates.